All right. So with that, you can go ahead to the next slide. I just want to do a quick introduction. Before I do the introductions, I do want to say if there are groups who are part of the webinar today who are doing work similar to what Diana and Andrea are going to talk with us about today, we'd love to hear about it. We may do a more extensive webinar with more organizations that are doing something similar. This is a really innovative program and an opportunity for potentially a pretty decent source of revenue. So tell us about it in the chat. We'll keep track of it. So with that, I want to introduce Diana Dorn-Jones, who is the Executive Director for United South Broadway Corporation, one of Albuquerque, New Mexico's oldest nonprofit CDCs. Currently, they focus on statewide foreclosure prevention, and they operate a one-stop shop that provides HUD certified housing counseling and loss mitigation and free legal defense for income-eligible homeowners facing judicial foreclosure in New Mexico district courts. Also, Diana is joined by Andrea Botero, who oversees public health integration for Presbyterian Healthcare Services and is an independent public health consultant currently working for USBC. So I'll let you all take it from here.
Well, thank you very much, Ellie, for the introduction, and welcome everyone. I'll say good day, and I won't say good morning or good afternoon because you're from all over the place. So good day. I want to thank Bruce, Ellie, and Ebony, the team there that helped us get ready for this. I just want to briefly say that we didn't get into the community health worker looking at the time because we've been looking at this for a couple of years, actually talking about it with Andrea, one of our community partners with Andrea is. And we were looking at it from the standpoint of the work that we currently do, and that is in the world of foreclosure. We do statewide foreclosure. We have legal housing counseling as well as legal services for people who are income eligible. In New Mexico, we're a judicial state, and so people get sued and they have a day in court. So if you're income eligible, we will work with you and provide you with free legal services. What we find, though, is that when people are going through foreclosure, they've been through a lot of agony and a lot of stress on the way there, because when you get down to losing your home, you've lost almost everything. And so our clients are usually pretty stressed out. So over the years, I've always advocated to have a social worker be part of this network. And it's pretty much fallen on deaf ears from the typical people that I talk to it about, like, that would be nice, but who's going to fund it? And so over the years, I've been having these conversations with Andrea about the community. One of our board members is Alma Olivas, is a promotora and was with the Robert Wood Johnson fellow. She was a fellow. And so she was very much involved in this, and she kept me posted all the time about the role of a community health worker. And so that's kind of how we got into it, because we've been looking for someone to help hold the hand a little further, a little harder, and provide more support for homeowners that are going through foreclosure and working with us, trying to get to the other side where we can save their home or at least transition them out with some dignity out of their home if that's what it comes to. So today, right now, USBC is working to have all of our housing counselors to have certification as a community health worker, and working with Andrea and her group to do that training, and she'll talk a little bit about that. And then most recently, this work kind of came in handy because we were approached by the United Way of Central New Mexico, and they had a grant from a private funder, private foundation, that wanted to work with a group like us that works with households, families. And in this case, they were looking for people, organizations that work with families that were serving children age 0 to 18. And that fit us. But our group, we're housing counselors. That's what we're skilled in. We're getting more and more skilled and trained in the area of community health workers. But that's when I call on my community partners. So that's when I called Andrea and said, guess what? And I'm going to go for this. and accept this opportunity that we're going to need you all, the community people with a lot of skills and the community health worker with a history and a network, an established network through the state of New Mexico and through many organizations around the state to help us carry out this work. And so we presented to United Way a little bit different of a model than what they were looking for. They were quite pleased to see it. They had no idea this network existed. And so they said, we've talked to our founder, the foundation that gave us this money, and it looks like they want to start doing this with all of their grants and look for a broader spectrum of how they can serve the clients that they want to touch base with and give them the services needed to get through what are really difficult times for all of us right now. So I just want to say that now is coming in handy because I also know I'm a recovering banker by profession, and I've always known the importance of having a diverse funding portfolio and not having all your dollars come from one source, because if that source goes, you're flat. So we saw this as one more opportunity in today's environment to expand our portfolio and where our funding comes from. So that's kind of how we got into it as a nonprofit organization. And so I'm going to turn it over to Andrea, and she's going to give you the nuts and bolts. And then we're going to try our level best to answer any questions that you may have. If we don't have the answers, we'll get back with Ellie and make sure we answer those questions or give you a referral where you can get an answer. So thank you again. And I'll turn it over to Andrea. Thanks, Andrea.
Thank you, Diana. And yes, we started this work a really long time ago. I remember Diana coming to me and saying, my clients are not happy. How do we get a social worker in? We really need to address their mental health concerns. And then from my side, working in healthcare systems, seeing individuals that cannot control their A1C, and when you're asking them what's going on, they're heightened because they're in the brink of losing their home or experiencing homelessness. When I was just out of grad school with my public health degree, I met an individual who was handed a nebulizer, and this was an unhoused individual. And I just thought that was the silliest thing we could have done. Next slide, please. So we really started thinking about housing as part of the social determinants of health. It's been seen both through your lenses and also through hospital lenses. Social drivers of health are defined as conditions, environments where people are born, live, work, that affect a range of healthcare outcomes. And like I said, it's been widely recognized to be an important social drivers of health. At the hospital system that I work in, we look at three different things. We, of course, look at, are you feeling safe at home? Are you in the brink of experiencing homelessness? And are you in the brink of experiencing not having food? And we really started partnering with housing organizations to create a holistic approach in how we are tackling these things. As you can see in the slide, housing is a pivotal part of the public health ecosystem. Organizations like Diana's are trusted anchors for families. We see it as a way to eliminate gaps through integrated housing solutions. So housing programs to address multiple health risks simultaneously. And another example of this can be in New Mexico, we have a water testing and community health workers are being trained to test water. And then a holistic approach as housing as a public health practice. So again, public health initiatives are increasingly focusing on housing to address health disparities. Next slide, please. So why does it matter? So 70% of low-income individuals spend more than 50% of their income on housing. Eviction is associated with a 1.5-time increase in emergency room visits. As I asserted, we had individuals with very uncontrolled A1Cs because of that endocrine jump in their due to their hormones and just being unable to manage it due to stress. People who are evicted experience increased rates of depression and anxiety, as Diana had seen throughout her clients. And eviction is linked to 1.5% increase in ER visits and hospitalization. And according to the American Academy of Pediatrics, children who experience eviction are at higher risk of asthma, brand new moms giving birth with low birth weight, and academic decline. Oh, and thank you, Ellie. Yes, A1C is the test that you do to check what is your blood sugar levels. Next slide, please. So what is a community health worker? And of course, it has many names. So community health worker, promotoras de salud, community health representatives are used in tribal communities. So community health workers are public line healthcare workers who apply their deep understanding and experience, language, and our culture of their communities they serve to carry out one or more of the two following roles. Community health workers traditionally come from the communities that they serve, hence promotoras de salud and community health representatives. They are the bridge that provide culturally appropriate health education, information, outreach in community-based settings. So they go to homes, school districts, housing centers, local businesses, and community centers. In New Mexico, we have a lot of community health workers working in faith-based organizations. They serve as a bridge between individuals and public health systems. And they are there to build the capacity of those communities. As an example, they are trained in diabetes prevention. They're also might be trained in climate change, resilience, and different other specializations. They really help assist people in accessing the services they need, and they provide direct services such as social support, care coordination, and health screenings. As an example, at Presbyterian Healthcare Services, we do train a lot of our community health workers to be frontline mental health aides. And they, of course, advocate for individual and community needs. Next slide. So what's New Mexico's landscape? So we're the 5th largest state, but 36 in population size. 21% of homeowners are cost burdened. 43% of renters are cost burdened. And that is according to a New Mexico Affordable Housing Needs Assessment completed in 2023. But from 2023 to 24, New Mexico saw a 20.5% increase in people experiencing homelessness. And there's also a very big disparity in those statistics. Our Native American communities, even though they only make 10% of the population, experience the highest percentage of homelessness in New Mexico. Next slide, please. So what do community health workers do in New Mexico? So they address basic needs such as food and shelter. They navigate health and social systems. They assist with enrollment in health programs and services. They coach on problem solving, self-care like diabetes care and self-management. They promote understanding of health information and health education materials. But they also do this with other systems, such as understanding of how to navigate FEMA when there's a fire. They lead educational and support groups. They conduct home safety assessments, such as the water testing that I was speaking about. They measure and respond to vital signs. So we do teach community health workers how to do blood pressure, how to do A1C, diabetic foot exams. And they provide feedback to medical and legal providers. The reason that I put this slide in this presentation is because of what we will be talking about in a minute, and that is around billing and coding. Next slide, please. So in New Mexico, there is an ability for community health workers to bill Medicaid and Medicare. I have put the rates that are available for 2023 and 2024. So they become a provider for the managed care organizations. And as a provider, they can submit claims through the provider portal when they see families, communities, and provide services. Currently in New Mexico, for 30 minutes of education and training, a person can bill $30. There's not a cap. So if you're taking a client to, for example, the Social Security office, and you spend 2 hours, so there's not a cap, you can bill for those 2 hours that you're with the client. But there is a cap on how many clients you can see per day. They don't want you to extend more than a billable 6 hours per day. Next slide, please. So how can they do this? In particularly if a community health worker does not work in a healthcare system. So the New Mexico state has a standing order that says community health workers and community health representatives do not need to obtain an order from a physician or a clinician when they see a new Medicaid member. So this allows promotoras de salud, community health workers to have greater autonomy on how they serve and how they serve the most vulnerable Medicaid members. As healthcare systems, we also recognize that we're not a trusted service. So sometimes they feel safer going to individuals and organizations such as Diana's to get services, more so than going into a hospital. So how do they bill Medicaid? So in order to do this, they must first get certified as a community health worker. In New Mexico, it requires 100-hour training plus 20 hours of community service that you are overseen by another seasoned community health worker and certified community health worker. After that, you must enroll with the New Mexico Medicaid as a provider to complete a provider participation agreement. So you literally become a provider for a managed care organization and you get an NPI number. They must always verify a member's Medicaid eligibility using the New Mexico Medicaid portal. So we have a state portal where you can see an individual if they have Blue Cross Blue Shield, United, or Presbyterian Health Insurance. And then they complete a standing order as named here, and that's how they submit a claim. So they put, I saw a client that needed a new air filter because there was a fire close by, and they write it down and they bill and code the codes that you saw previously. Next slide, please. So we really thought, and this is something that Diana really came up with, that when a community health worker understands the housing system, they can prevent the crisis. But when a housing counselor understands health, they can protect the whole family. Next slide. With the grant that we received to pilot this project, we are developing a workforce trained both as community housing counselors and community health workers to ensure a holistic person-centered approach to addressing homelessness and other key social determinants of health. So for us, when we received this money through the United Way of Central New Mexico, was to create a way and pilot how does a community health worker in the processes of Diana's organization, how will they work with the lawyers and other housing counselors, simultaneously training community health workers as housing counselors and vice versa. We would love to train all of Diana's housing counselors into community health workers so they can bill and code for the services they are providing. Next slide, please. So, why? What does it look like? What is a USB CHW housing counselor? So they are professionals for both certified housing counselors and state certified community health workers. And they bring uniquely powerful skill sets because not only do they navigate housing systems, such as foreclosure prevention, but they can address social drivers of health. So how to make referrals to our local food banks, how to enroll individuals in Medicaid and TANF. In New Mexico, when you're a community health worker, you become a PIMOSA enroller, meaning they themselves they have a website and they can enroll individuals into the Medicaid portal. But also with TANF and SNAP and other federally and state recognized programs. Also, they can address frontline behavioral health care and education. This also brings long-term stability. So we are seeing with the clients that we have that as we get them in track using family goals, using like the Arizona self-sufficiency matrix, there's other kind of tools such as the pathways. As we help them, gain stable employment or making sure that they have food in a daily basis, that it mitigates a lot of their income, and also it mitigates and creates a pathway to stability. Next slide, please. So what are some of the benefits that we've seen when we have this dual training? So for family, is one trusted point of contact who understands both housing and health. We're seeing that it's more culturally and linguistically responsive support, and we're seeing that there's more effective referrals and follow-up. We're also utilizing a platform for referrals called Unite Us, which is helping us navigate the system and making sure that when we do refer a client, let's say to get a food box at a food bank, that they are getting that food box at a food bank. Or if, for example, they need help with transportation to get that food box, we're there to help them. So for professionals, we're seeing an expanded scope and increased job opportunities, and they themselves are seeing deeper impact with the families that they're serving. We're seeing more confidence navigating public health systems like TANF, SNAP, Medicaid, and community programming, and their ability to advocate both at individual and policy levels. The richness of the stories that they're bringing are more impactful, and we're able to see those larger ecosystems, in particularly as we're writing grants or as we're talking to our legislation. So for systems, it also helps reduce fragmentation and duplication of services. It supports upstream prevention and reduces ER hospital usage. There's great literature around how community health workers really help reduce emergency room visits. And of course, it builds stronger and healthier communities. In New Mexico, that is such a rural state where individuals have to travel many miles to get the supports that they need, we are also seeing that it helps navigate those services when a person needs to travel 2 to 3 hours just to get a behavioral health appointment. A community health worker and housing, as an example, if we're able to get him a telemedicine appointment, but it's an elderly person, that community health worker can not only help with the housing, not a certified community health worker can not only help with the housing, but also help that family navigate how to use telemedicine for those behavioral health. Next slide, please. Please forgive me. This is the newest map that I have seen about states that allow for Medicaid payment for services provided by community health workers. I am saying this because I know Texas and Arizona are now eligible to bill for community health workers, but I scrounged the internet and I could not find a newer map. But like I said, this was in 2022, but currently, as an example, Texas and Arizona are billable states for community health workers. But in a national level, as you can see in the lighter green, there's a lot of states that allow for community health workers to bill and code for service. Next slide. Understanding that Arizona and Texas are now eligible to bill, each state has its own guidelines of standing orders, how you're going to bill, and how your Medicaid state office has built. So for me, it's really important to delineate that you can find state-specific guidance at state Medicaid website and provider portals. Call your insurance companies. They usually have a provider individual that can help you navigate the services, and that's their role. Please look also at the State Department of Health or Social Services. The National Academy for State Health also has really great information, and some of these have links. And the Kaiser Community Foundation has a lot of information around state policies for expanding Medicaid coverage of community health workers. And of course, the Centers for Medicaid and Medicare Services. Next slide. And here are some of the exciting resources. Because some of the things that we have seen, or some of the lessons learned that we have seen throughout this process, is because community health workers were not able to bill and code for services until last year. that there's still a lot to teach and navigate around the billing and coding piece for community health workers. When they work at healthcare systems, it's kind of acclimated. It's a culture. We know we have to bill and code, but for individuals that work outside of healthcare systems, developing processes and really learning at how to do a patient note and how to tie it to that bill, that code has been really interesting. We are very lucky to live in a state where larger systems such as the University of New Mexico and Presbyterian are gathering all of those informations and passing it for free to community-based organizations, in particularly those that are not healthcare. So we are looking in seeing in how we can train community health workers that are at churches, that are at housing locations on how to bill and code so they themselves can also become sustainable. And like Diana stated, when we are doing this intraprofessional collaborations, this health and housing, there's a larger ability to apply for grants that were not usually in your purview, because not only are you helping navigate housing, but you're also helping navigate getting food or accessing healthcare, and then mitigating when a family comes and is super stressed out, mitigating that mental health first aid. And thank you so much. And I guess it's time for questions.
Great, we have a few. So folks, if you have questions, now's the time to get them into the chat box or into the Q&A, excuse me. Don't put them in the chat box, put them in the Q&A. Okay, so just a quick question about the United Way funding. Is it through the Seymour Institute? There are currently a handful of, I see a lot of head shaking, housing counseling agencies currently partnering with the Seymour Institute. And this is from Karen Hausneck-Yetman from Belmont Housing Resources in Buffalo, New York. And she says you can always reach out if you want to talk more. And Karen, if you want to pop your email into the chat, that's great. So go ahead, Diana, and answer the question.
It is through the SEMA Institute. And United Way went for that grant. And of course, they don't do those kind of direct services. So they were out searching around for someone, and our name came up because we're a housing counseling agency. We're HUD certified, and we're a civil legal service organization. But I tell people we're a grassroots community organization that just so happens to provide these other services. And we're always grounded and rooted in housing. So yes, it is the same one, and they are looking at what we're using with this community health worker network, because they had never seen it. And I'm hearing that maybe they have, because other groups here are doing it. But perhaps it's our local United Way that's having to build their capacity to understand it. As a matter of fact, we have another meeting with them next week, because we're meeting way more of their goals than they set forth in their grant through this network. So it is that, and we would like to reach out and have a conversation with you.
And I feel like even though in my work with the CHWs and really navigating that space and building the processes for the CHW/housing counselor, what we're seeing is that we're able to provide larger amount of services, some of them that require a lot more time. So as an example, one of our community health workers went with an individual to an immigration office. That took a very long time. So how do we mitigate that quality versus quantity, and then situating housing not only as a stop and go or fast food restaurant, but it's really looking at the patient as holistically and making sure that we are creating the structure helping create the structure in their lives that they can sustain the things that they need to live in a better way. So mitigating their health, mitigating housing stability, and other things.
One of the important things for us is that for housing counseling agencies that are on the line here, is that we ask for a lot of documentation, and a lot of follow-up is required. And those documents age out if our client cannot jump to get on that task right away. So now we're able to send someone out And I'm thinking of hiring the people that are not only our housing counseling staff, but other people to support the housing counseling staff, that they will actually go to the home and help people find those documents, write for those documents, get what they need so that we can be more responsive to their housing needs. And we find that that's going to be very helpful to us because it is. I mean, people work every day. They don't have time. Time is a privilege, and that's not afforded to everyone. And so we're trying to find the easiest way to help our homeowners to get what we need to help them. And sometimes they need a helping hand, like a certified, health worker.
Okay. Oh, this is a big question. With the anticipated reduction in Medicaid, are you concerned with the continued funding / billable services for community healthcare workers?
Yes.
Yes. Um, but I think not in New Mexico as much as I think for Medicare patients. So Medicare, we bill for CMS, but for Medicaid, this is really a New Mexico state-driven initiative, and they've actually augmented the provider types that are able to bill. As an example, not only can community health workers bill, but also doulas and lactation specialists have become two of the new billing providers as of this year. Because we're such a frontier and rural state, and literature had shown the power of community health workers, it is something that the state has doubled down on to make sure that these are billable services for at least the next 3 years through under the Turquoise Care contract that just came out. It's a Medicaid contract that lasts for 3 years. I think all of us healthcare systems are incredibly afraid of the Medicaid cuts. And I have seen a lot of funders, such as Kellogg Community Foundation, waiting to see what happens, to see what they're going to fund. As an example, funding direct services such as midwifery and doula, it is going to become much more important than other auxiliary services because they can keep babies, alive. So yes, there is there's a hesitation there. So yes.
I was very interested to hear about the upcoming webinar that you have around foundations, because I think we're going to have to start looking more and more to foundations to pick up some of this and to participate with the public sector to fund some of these positions.
I think we're all having to do that.
Yes.
Okay, so I think that you all addressed this question, but let's talk about it again just to put a finer point to it and make sure everybody understands. So this is only for New Mexico?
So no, you are able to bill for CHW services in many states, 29 plus those two that are in the PowerPoint presentation, Texas and Arizona. What you need to figure out is around, in particular, if you're not a healthcare facility, how do the standing orders work? So you don't need that physician, certified nurse practitioner to co-sign the order. In New Mexico, we just have a standing order that a community health worker can bill and code for the services that are delineated in the scope of work. And housing is part of that. So I would really recommend that you guys go to those websites that are listed in the PowerPoint presentation.
And we did put the links. Here we go. So I'm going to put these two links into the chat. Okay. So the one link gives you the policy tracker by state, and then the other link is with the Kaiser Family Foundation, and it lists the state Medicaid policies. And I think, Andrea, that's where you got the map also, right?
Yes, ma'am. But also please check with your Medicaid offices and the Health and Human Services. As an example, in the state of New Mexico, at the Department of Health, they have an office for community health workers. and they created a toolkit to help individuals bill and code, and they are the ones who are certifying community health workers. So I would really encourage you guys going to the Department of Health websites of your state.
Oh, State Department of Health. Okay,
Yeah.
good to know. Good to know. Why did you choose this model instead of working with a medical legal partnership?
Diana, I'll start it and you finish it. I think New Mexico, in particularly because of we're a majority minority state, the individuals that we serve, I think, are legacies. For me, it's really important to have a community-based participatory research in action approach in how we are working around social drivers of health. Having a community health worker who is a trusted member of that community help navigate systems, abstract voices and stories for policy, and make sure that we are implementing the things that they need and working with them to develop those programs was very important to me. But Diana, what is your take on that?
Well, we've been around doing housing and this work for almost 40 years. And I don't want us to lose track and lose sight of what we are here to do. And I do believe that we are much more effective as an organization if we create community partners that have the expertise, but that we oversee the segment of the work that we want to have done, that we oversee it and look at it through the two things, through the lens of housing, affordable housing and equity for people, and as well as through the lens of race because of New Mexico's population. And so we don't have to be an expert at everything, but I think we have to become a good community partner that's out there that is in touch with what's going on. And it's clear that we have a very close, by the time you work with us, we know everything about you. Okay, there's no skimming and telling us one thing. We know, okay, because we have to know everything about your finances, your family, everything as we start to walk around keeping you in your home. But we can't be an expert on everything. And I think it's a good way for us to augment our capacity to do a better service for the people that we're working with. We're not mental health people. We're not social workers. We're charged with doing a lot of referrals, but those referrals are kind of like soft referrals. We'd like to be able to do that pass that hand referral and have someone that is accountable to our organization for the work that they do for us and for the clients that we serve. So we can't be everything, but we can join and be a part of a larger network of resources that are out there that we know are critical to keeping a family healthy. And we hear more about this than probably the community health people do because people are coming to us for something very specific. How do they stay in their home, whether it be an apartment or whether they're buying their home? But what we can be is better partners and not be isolated and doing just what we do, but be broader support to the community.
And I work for a healthcare organization, and for me, having community health workers work in community-based organizations like that is incredibly important, in particularly because of the families that we serve. As I was reading earlier, even though Native Americans make 10% of New Mexico's population, they have the highest rates of homelessness in our state. When we talk about legal state partnerships, we also have to, where do Native Americans access care? How do they access care? Which is usually through Indian Health Services and are very situated into their service areas and into tribal communities. But if they are unhoused in urban areas such as Albuquerque, how do they navigate those healthcare services? Because their insurance doesn't really allow them to go in, or they would get billed as an individual if they do not access care within the Indian healthcare coalition or partnership. So for example, if they go to Presbyterian, we would send a bill to them because they didn't go through the proper channels of Indian Health Services. Community health workers understand that and have an ability to navigate different payment systems, have the ability to work closer with community health representatives to help individuals navigate who are underinsured, not insured, and just the plethora of different healthcare access that an individual has. So we really like that more than just partnering with a hospital or a federally qualified health center.
Okay. So since Oklahoma doesn't allow billing to Medicaid, and first of all, that's probably going by that state, but I would encourage you to please call your Medicaid office, since that map that Andrea put up for us is 3 years old. So be sure to contact your Medicaid department directly to make sure what the most up-to-date information is. But I think really the question here more is about, would we be able to apply for a grant? So like thoughts about, are there any thoughts about, other than United Way, are there other places that people could be thinking about for applying for a grant for this kind of work?
I know Kellogg Community Foundation has provided a lot of funding for community health workers in the past. Kaiser Community Foundation. I think this partnership between housing and healthcare really allows for that opening up of services. I know it's a little bit like during COVID, there were a lot of federal grants around community health workers because they saw them as a frontline staff in providing education around vaccination and also helping people navigate systems. Then I don't think they're available anymore, but I know the states have picked up some of that work. So the Department of Health has some grants around community health workers.
I think one of the things that we can do as housing organizations with nonprofits is that we have to begin to inform the private foundations about what the needs are out here. I would strongly support looking at Kellogg, because they're kind of looking at some of this already. We need to have them go deeper. Robert Wood Johnson's foundation is another one. The Casey family programs, and then Marguerite Casey Foundation. We were funded by them for 17 years, which these are organizations, grantors that go long and they go deep. For 17 years, they provided us with that because they felt we were unique, and that not only were we a housing organization, but we had our tentacles working with all kinds of organizations and a real broad network of services that families need. So I think it's our job now in these times to be the voice from the ground with a megaphone saying, you guys, what you're funding right now, like some of the foundations have gone into book clubs, reading about anti-racism and book clubs and working in university campuses and that kind of thing. Well, that's not where we need you now. Families need you on the ground. And we're hoping to have a conversation coming up with a couple of funders that we've had in the past, and saying it's time to shift back to those services that are direct to the home, to families, because book reading is great. It's very important that we be knowledgeable of what's going on, but there are families in great need, and foundations may be the answer to what's going on in the government and how we bridge the gap that's growing. So I'd like for us to be influencers around how foundations do their granting going forward.
So somebody had asked about putting the names of the foundations in the chat, and I think I caught the ones that you mentioned. Was that right, Annie E. Casey?
Yes, and then there's the Marguerite Casey Foundation.
Marguerite Casey. If you could pop that in there while I'm asking the next question, that'd be great. But the other ones are that I put in there: Robert Wood Johnson, Kaiser, Kellogg, and Annie E. Casey.
Yeah.
And TYSM, I'm not sure. Oh, thank you so much. Okay. I thought that was another foundation. That's funny. Okay. So Andrea and Diana, this person would love to have your contact information. If you both wouldn't mind putting your email addresses into the chat, that'd be great. Yeah, put it in the chat, not in the Q&A, so that everybody sees it. Thanks. Okay, is the telehealth model virtual for providing services via CHW and allowed billable format to provide the services?
Yes, ma'am. And it does have a modifier that you have to add to the billable code. But in the state of New Mexico, you are allowed to have virtual telehealth models.
Okay. Let's see. I'm not sure exactly what the question is asking about specifically, but the question is, what is the staffing capacity of each organization? I think maybe there's a misunderstanding. We're talking about one organization here. So what is the staffing capacity of your organization, Diana?
We have 5 full-time attorneys. We have 4 certified housing counselors that have passed the new test. We have 2 that are in training. And then we have, of course, administrative support staff. So we have a fiscal manager that comes in so many days a week, and then, of course, myself and another manager. So we probably have about 20 or so. We also use the Public Ally program. We're starting to pick up on public allies and using them to help. A big part of the work, as I said, is making sure we do document collection, and we're using public allies to do that as well. And so I'll probably get them to be trained as CHW workers too. We all need to be singing from the same book.
Okay, so 2 kind of questions that go together. Are all the clients that you serve recipients of Medicaid, and is there any liability that comes with being a CHW?
Not everybody that we serve are Medicaid members, but what it has helped is covers. We're able to bill for a vast majority of individuals. We do not turn anybody away if they don't have healthcare insurance. That's very important for us.
And there's no means testing either, right? Because we haven't had anything where I'm had to do means testing, so that keeps it within the framework of the HUD Certified Housing Counseling Network.
And according to like the American Hospital Association, the Network for Public Health, there is minimal liability for community health workers to bring risk to employees. I think what the state of New Mexico does really well through the Office of Community Health Workers is reinforce the scope of work for community health workers. They are very, as an example, not only do you have to get certified with the 100-hour training plus 20 hours of field work, but every year you have to recertify your community health worker with 45 hours of community health worker training. 90% of the trainings are done for free by various community-based organizations, the University of New Mexico, Project ECHO. All of their trainings are available for community health worker education hours, and there's a reinforcement of scope of work. And just as through this pilot that we're doing with Diana, we did hire medical provider to help us create policies like this is the scope of work. This is what we understand that you will be doing, community health worker / housing counselor, and anything over that scope of work, please refer out. There are instances, but I think these are instances that we see even if there's not a community health worker. As an example, that if a patient states, I just want to die. So making sure that we just have those policies for like suicidal ideation. What do? We tell Diana, hey, Diana, this person, told us that this wanted to die, and making sure that we're connecting them to a crisis help as soon as possible.
Okay, and one more question. Are you working with code enforcement departments? In the Healthy Housing Collaborative I started years ago, we partnered with code enforcement departments to educate families on how to keep their families safe from lead, radon, and other hazards when enforcement was being done.
I love code enforcement. I have a very close relationship with the people in code enforcement, and I would encourage people to do that because really some of the issues associated with keeping people in their homes are code violations. And so wherever I can get little pots of money to cure small home repairs to do that, we help the family to cure that. We definitely want to keep the water on because that's if the water gets cut off, then it's automatically it's a red tag and you can't come into the home. So we it's important to know the municipalities and know their code and code violation and have a relationship with them. The other thing is that we find that people that are working out there, the gas company, the utility companies, code violation, they know they're visiting those properties all the time. They now tell people when they can spot the signs of someone in trouble with their mortgage, and they have our cards on them and they refer them to us. So they become a source of referral to our services for these homeowners.
That's great.
As an
Really.
added piece, and I know it's not really about, but it is a lot about how to keep families safe. And we're currently working with the professor at the University of New Mexico to create a specialization for community health workers around how to help families navigate systems through community health workers, in particularly after fires, dust storms, and other events that are affecting their homes, but also affecting their health. So we're creating a specialization alongside the Department of Health for community health workers in that regard. Which some of it has to do with code enforcement, like are they safe to come back or can they navigate FEMA and other resources?
And are there other certifications that housing counselors can take aside from the CHW that you think would be beneficial to integrate?
I don't know. I've always thought, Diana, and peer support workers are another healthcare type, and they're individuals that have substance use disorder issues, other kind of, I mean, a peer support worker can be somebody with lived experience that have, experienced stillbirth or spontaneous abortion. But I think peer support workers could be another provider type that could work really well with housing, and particularly individuals who have experienced houselessness, and helping others that are in the brink would bring a richness into the services.
You know, we've leveraged our reputation in the broader community to get big like COVID-19 grants from HHS, Office of Minority Health. We were able to navigate our relationship as in the community by being able to go to the county and telling them we need you to be the applicant for this, but the community will run it. Okay, so we were able to bring that to the table, and so we did door-to-door canvassing during COVID and letting people making sure people were vaccinated, holding community health events. So I would encourage people to not to think we don't want to lose our focus on housing and who we are as organizations, but I think we have to be creative about how we leverage our long-term relationships and reputations in the community to bring other dollars. But for USBC, the South Valley Main Street, Casa del Rey Ministries, they would not have been able to pick up the phone and call the right people at the county, get their confidence to get it to the county commission to take a vote that they would accept that $3 million and let us run that program. We learned a lot out there about what housing, the condition of housing by going door to door. We found out what some of the big issues were around rental issues as well as home ownership, over burdened households in terms of a lot of people living in one home and trying to make it together. Vacant and abandoned properties that could be put back on the market if they were given attention. So we became a real resource to our broader community because we were able to step into that space. So I would say, let's not be afraid to step out of our comfort zone and do other things, because most housing groups have have a good reputation out there. They're helping people.
Well, thank you both so much. I do want to bring on one organization that did say that they are doing something similar in New York State. So Karen Hausneck-Yetman from Belmont Housing, I made her able to speak with us. So Karen, go ahead. Tell us about what you're doing in Buffalo, New York.
Hi, Ellie, and thanks for letting me unmute. And I'll just talk about this real quick. And I just want to say thank you to Diana and Andrea. Like, your program is so beyond what we're doing right now, and you're doing really great work. We just got started on this about a week ago, so pretty new. But it's more just talking more about New York State and what's going on, and if there's any other counselors here from New York State, to contact the place in your area. That through what's called the Medicaid 1115 waiver. The New York State Department of Health has created these social care networks, and there's one in every region of New York State. And through that, they have these screeners who are screening people who are on Medicaid to see if they qualify for what they're calling enhanced services. Enhanced services include nutrition assistance, transportation assistance, and housing assistance. And we're seeing that a lot of people we're already working with are already receiving Medicaid. So it's not anyone different than who we're already serving in the community. And so if someone qualifies for these enhanced services, we can help with funding to help, people who are unhoused that we're helping find housing. They can get money for security deposits for a few months of rent. If, eviction is going to happen because of, being behind in utilities, we can help with utility assistance. If someone isn't able to stay in their apartment because of asthma issues and something happening within the house, there's money for repairs to the unit. So there's all these things that are happening with this Medicaid 1115 waiver across New York State. And so I think a lot of states are doing things like this. So just kind of reiterating what was said already, that talk to your, state health department to see what they have going on. And if you're in New York State, definitely talk to your local social care network. Thanks, Ellie.
Thank you, Karen. And I did pop a link into the chat that Karen had put in earlier. I just kind of copied and pasted it again for everybody's view, where you can kind of take a look at what she was just talking about.
Wonderful.
So again, thank you both, and thank you, Karen, for coming on. Thank you, Diana and Andrea. Andrea, did you want to say something before?
Yeah, parting words as well. So CMS, Centers for Medicaid and Medicare, have made it that all hospital and insurance centers look at patients for social drivers of health. Like I said, as a system, we're looking very much into houselessness and also food security. I would also encourage you guys to reach out to your managed care organizations. They also might have funding for some of these special projects, and would be or love to partner with community-based organizations to best mitigate, because it's not just about like, oh, you're experiencing food insecurity, what next, right? Or you're experiencing homelessness, what next? But really, they want to partner with organizations that they can refer, and sometimes they do have grant funds available.
Great.
So.
All right. So again, thank you both very much for an incredibly informative webinar.